Good morning, everyone. Please help me welcome Dr. Ismigna. She is a clinical assistant professor of pediatric pulmonology at UF. She completed her pediatric residency at UF and completed a fellowship in pulmonology at the University of Arizona. She joined us today to talk about the pulmonary complications of sickle cell disease and multidisciplinary clinic. Thank you.
Thank you very much. Good morning, everybody, and first of all, thank you very much for inviting me to talk to you today, and also I appreciate you taking the time to attend this lecture. Our topic for today is, as you can see, pulmonary complications of sickle cell disease, and hopefully during, I have nothing to disclose, obviously, and hopefully during this lecture, we will be able to go briefly over the epidemiology and pathophysiology of sickle cell disease. And we're going to then talk about the most commonly known pulmonary complications of sickle cell disease. The things that I want you to learn about today include acute chest syndrome, asthma, pulmonary hypertension, abnormal lung function in sickle cell disease, and mainly restrictive lung disease. And also we're going to talk about sleep disordered breathing in sickle cell. And finally, I will give you maybe a couple of slides briefly to talk about our project of the multidisciplinary clinic for sickle cell kids at the University of Florida in Gainesville. So to start, as you all know, sickle cell disease is a very common disease. It is inherited as an autosomal recessive disease, and it results from a point mutation in the beta globin, forming the hemoglobin A, the adult hemoglobin. And the point mutation is usually, as you know, a replacement of valine for glutamic acid. And this results in a very common monogenic disorder worldwide that affects mostly the African American population. In recent epidemiological studies, it was found that approximately 8% of African American population in the United States are heterozygous for the disease, which means that they have their sickle cell trait patients, and 1 in 600 actually have homozygous mutations, which makes them sickle cell disease proper. Also, it's common in other areas of Africa, as common as 40 to 60% to carry one mutation or be heterozygous for the disease. So you can see how common it is, especially in the African American population. So I'm sure you remember this from biochemistry, but just a nice little review. So what happens when you have this point mutation? You have a defective hemoglobin, which is hemoglobin S. What's wrong with that? Then, you know, this resulting hemoglobin is very fragile. So it results in hemolytic anemias when the subject is under certain stressful conditions, as you recall also from your early medical school years: dehydration, hypoxia, infection. It's all stressful conditions to that hemoglobin, so it polymerizes under deoxygenation conditions, and there's RBC distortion, there's rigidity and less flexibility of the RBCs, there's membrane structural changes, and finally this will affect the rheologic properties of the RBCs, and the blood flow will not be as smooth and normal, and this will result in vaso-occlusive crises and other catastrophic complications that we're going to go over briefly. Now, as you know, the worse the polymerization, the worse the hemolysis, which indicates worse actually stressful conditions and worse deoxygenation. As you can tell by looking at the figure on the right side, at the end, sickle cell disease is a multi-organ disease, right? It affects almost every organ in your body. It can affect the brain, you can have strokes. It can affect the cardiovascular system, which is the focus of our lecture for today. It can affect the kidneys, the bones, the skin, and even the genital tract. Also, there are different traits of abnormal hemoglobin B, as you recall also from biochemistry and hematology. We have hemoglobin C, which is another point mutation, a different one in the beta globin of hemoglobin. And some kids actually can have the trait HBSC, which is a little less severe than HBSS when you're homozygous for the sickle cell trait. And also there's a mixture of thalassemia and the sickle cell when you have the sickle beta thalassemia disease. So let's start with the most serious, if I want to say that, the most serious pulmonary complication of sickle cell disease, which is acute chest syndrome. And I'm sure most of you have probably have seen that in your training at this point. So what is acute chest syndrome? It is one of the very common acute lung injuries in sickle cell disease. So in order to diagnose it, you gotta have to have a clinical situation and a radiological evidence of this acute injury. So the clinical situation usually is actually non-specific. So you will have the patient present with cough, with wheezing, fever, chest pain, and of course different levels of respiratory distress depending on how bad it is, with hypoxemia, retractions, and so forth. And also you need to have a radiological evidence of this acute injury. And for us, when we start with the chest x-ray, it's going to be alveolar consolidation that involves at least one segment of the lung. And this consolidation, as I stress on consolidation, it is not atelectasis. So you have to be able to differentiate on the chest x-ray when you have this patient, is this atelectasis or alveolar consolidation that matches the definition of acute chest syndrome. Now, why it is very important, acute chest syndrome? Because until maybe the last decade or so, it was considered to be the leading cause of premature death in sickle cell disease. Nowadays, we're paying more attention to pulmonary hypertension. So if you read the literature, you can see some authors actually put pulmonary hypertension as number one. Some still put sickle cell disease, and some, of course, put them together, because eventually, when you have a lethal situation with an acute chest syndrome, the mortality usually results from having pulmonary hypertension and right heart failure. And you're going to see that as we progress through the slides. Now, of course, with the more liberal and more aggressive policies for blood transfusion and exchange transfusions that our colleagues from HEMONC are following these days, we have less, mortality rate. There's a drop in the mortality rate nowadays compared to several decades ago, and also after the introduction of hydroxyurea, we have seen some reduction in the mortality rate, but it's still high relatively. It's like from 25 to 30% on an admission. As we said previously, when this happens, you expect to have pulmonary hypertension and right heart stress or right heart failure with the acute chest syndrome. And a very nice observation comparing adult literature with pediatric literature is that they just noticed that pediatric patients present with the acute chest syndrome, and adults patients usually develop that in the hospital 1 to 3 days after hospitalization. Some of them actually relate that to kids being more prone to infection, so that's when the infection triggers acute chest syndrome and they're admitted with that. And some of them say, no, it's because adults, kind of seek medical help more than kids when they start having the acute chest syndrome, the sickle crises with pain and vaso-occlusive crises. And then, of course, they develop that in the hospital. But it's just an observation. Now, this is just an example of how acute chest syndrome looks radiologically. So, is it your right? It's my right. On my right hand, I can see the chest X-ray that shows you the alveolar consolidation involving the left lower lobe in a child with sickle cell disease. And I'm sure you can tell, this is not atelectasis, right? This is alveolar consolidation, because if that was atelectasis, this big, you're going to have mediastinal shift, right? and you're going to have a change in the pulmonary inflation comparing left to right lung. All we see is alveolar consolidation. And this is on the other image. It's a non-contrast CT scan for a patient with sickle cell disease, and you can also see the alveolar consolidation involving more than one segment of the left lung. So what is the pathophysiology underlying acute chest syndrome, and how does that happen? A lot of theories have been proposed and discussed as underlying mechanisms for acute chest syndrome, and by reviewing the literature, I found there's focus on three main mechanisms. Of course, it's multifactorial, and they can be integrated together, and we'll take a look at the vicious circle when one of them actually triggers the others, but we'll go over each one separately. So the most common, obviously, is infection, and then we have fat embolism from the bone marrow, and finally, direct pulmonary vascular embolization by the abnormal sickle cells. Let's start with infection. So what do we know about infection? There's a lot of literature out there. One of which is a very nice study reported by the National Acute Chest Syndrome Study. They looked at 671 cases of acute chest syndrome, and they were able to identify the microorganisms that triggered this infection. And interestingly, they found almost 50% of the patients growing in their BAL or sputum samples atypical bacteria or viruses, compared to only less than 10% to be community-acquired pneumonia, although we know, ironically, those kids have functional asplenia, right? If they were not splenectomized, medically indicated splenectomy, they at least would have functional asplenia, yet it was only in less than 10% of the cases. And of course, they found MRSA in the very severe, complicated cases with pleural effusion or empyema at the later stages of the illness and prolonged hospitalizations. And also, don't forget the role of influenza viruses, especially H1N1 in the season when you have a sick kid with acute chest syndrome. The other mechanism, which is fat embolism. So how does that happen? As I mentioned earlier, it's actually all integrated together. So if we start, you can look at the figure up. I wish I had a pointer though. But if you look at the figure up, you can see that a very serious, significant vaso-occlusive crisis, if it was bad enough to affect a large bone, like the pelvic bone or the humerus, it can result into infarction, necrosis, and release of a lot of inflammatory mediators that can actually hemolyze and release fatty acids and cells that can migrate through the bloodstream, and they can go to the lungs and they can lodge into the vascular system of the lungs. Now imagine when that happens, you're going to have maybe a picture of acute chest syndrome or PE, depending on the clinical picture. So you're going to have hypoxia, you're going to have ventilation perfusion mismatch, you're going to have shunting, and as a result of that, you're going to trigger more vaso-occlusive crises with the hypoxia resulting, right? So that's how you can tell it's a vicious circle. Now, interestingly, in the same earlier mentioned study, the acute chest syndrome group, they reported about 16% of the patients to actually test positive for lipid-laden macrophages in their bronchoscopies. Now, for the pulmonologists, I know you guys know what the comment would be. This is non-specific, right? So they wanted to use that as a marker of fat embolism, but I think the authors also agree that this is non-specific, and of course lipid-laden macrophages can be just a sign of chronic inflammation, can come from infection, and it also can come from exogenous aspiration. So that was just an observation in the Blue Journal. Then, as we said, it makes sense that when the distorted blood cells and the fat emboli lodges in the pulmonary vasculature, you can have pulmonary edema. And very nicely outlined in the Blue Journal, as cited below, some authors were able actually to report on CT angiographies some microthromboses that resulted in acute chest syndrome in the absence of a major big vessel involvement. This is also a nice angiogram in a patient with acute chest syndrome, and you can see there's a filling defect where the arrow is pointing, and that's causing infarction in the right lower lung vasculature. And again, just to give you another rundown of how the three mechanisms are integrated again. So if you look at the microorganisms listed on your right side, you can see the most common ones, the atypical microorganisms, chlamydia, mycobacteria, legionella, and other viruses. If they trigger infection, there is an exaggerated inflammatory response. There's release of a lot of inflammatory mediators, more than the normal population. You're going to have acute chest syndrome, hypoxia, more sickling, and more bone infarction. So what makes some kids more prone to have the acute chest syndromes or at risk of developing that more than the others? Younger age, obviously, as we mentioned earlier, because maybe they don't take care of their hydration themselves, right? So younger age, and that age being more prone to infections, especially viruses and atypical bacteria, also puts them under risk. Higher steady state hemoglobin, and that's because of the higher viscosity compared to lower hemoglobin levels. Higher steady state leukocyte count, the same. And acute drop of hemoglobin, and published nicely in the New England Journal of Medicine to be, if you have an average of 0.78 drop of hemoglobin in a hemolysis crisis, that puts you at more risk. If it was that cutoff or even higher, puts you at risk of developing the acute chest syndrome. And of course, that correlates with an increased level of LDH, right, with the hemolysis. As you also can predict, lower hemoglobin F levels can put you at risk. Chronic hypoxemia, example from obstructive sleep apnea or any other conditions that put you at risk of hypoxia. History of asthma in children, passive smoke exposure or active smoking for adults. And as we mentioned earlier, some traits are more severe than the others, so HBSS is worse than HBSC. An acute drop in the platelet count below 200,000, and that was actually pointed out in the New England Journal of Medicine to be an independent risk factor for acute chest syndrome. And finally, as you all know, operative and pre-operative risk, post-operative risk for the patients. So how do we treat that? First of all, you're going to have a low threshold for diagnosing this detrimental side effect or complication. So you have to have a low threshold for admitting kids who have a new abnormal finding on the chest x-ray with the aforementioned pulmonary symptoms. Hydration is very important, and it's actually a little tricky to provide the adequate hydration for those kids because you don't want to overdo it and induce pulmonary edema, hypoxia, and sickling, and you don't want to underhydrate them and have hyperviscosity and sickling. So the best way to do it, of course, is to be a little more careful with making up for the insensible losses like fever and follow different markers and different clinical markers for the hydration status. And euvolemic state is what we all want for those kids. Analgesia also is very tricky because you don't want them to be in pain so they can breathe well. Because if they don't take deep breaths and they don't breathe, make good inspirations and good tidal volumes, they're going to have atelectasis. Atelectasis will induce VQ mismatch. That will induce hypoxia. You will induce sickling, right? So, and at the same time, if the patient was opioid naive and you give them a lot of opioids as per their situation, you're going to induce also hypoventilation and hypoxia. So that's why it is recommended to start with non-steroidal medications, like for example ketorolac. I'm sure it's very popular here, and be careful with the kids who are opioid naive. Broad spectrum antibiotics, as we mentioned, just by what we expect, we can have third generation cephalosporins, we can add macrolides to that. If you can see significant pleural effusion and fever and empyema, you're going to suspect staph and community-acquired MRSA. You're going to add vancomycin. And if it's the season, you're going to check for the flu, and you're going to treat with antiviral medications. Incentive spirometry, it's very important to use incentive spirometry during hospitalization. As we mentioned, because you want them to take deeper breaths, you don't want them to have atelectasis, and you do not want to induce VQ mismatch and hypoxia. A couple of studies actually have shown that the use of incentive spirometry in the hospital, when you have a kid with a vaso-occlusive crises, that can actually be preventative measure from developing an acute chest syndrome. So that's why myself, I send those kids actually with an incentive spirometer at home. So whenever they have the pain crisis they start doing their incentive spirometer. Supplemental oxygen, or of course escalated respiratory support, depending on the situation. And of course I will leave the topic of blood transfusion and exchange transfusion for you guys to learn from the hematologist. What are the most recent guidelines and the cutoffs? But I know that they are more liberal than they were in the past. And very important topic for you, I'm sure you all want to know, what do we do with steroids, right? Is it recommended? Is it not recommended? So there's a lot of talk about steroids in sickle cell disease. And there's not a lot of enthusiasm these days about using it. And we're going to talk about why. So a lot of studies, they were contradicting each other, but they actually have reported detrimental side effects. They reported avascular necrosis with the use of the steroids, rebound vaso-occlusive crises, and an association with stroke, which all are serious complications. It's not something that you want to live with if you induced it to your patient. So what do we do with steroids? Where is this coming from? A very nice study published in the Journal of Blood, a little older study actually, but it's still a good one, and relatively small sample size, but they actually looked at 43 children who were admitted with mild to moderately severe acute chest syndrome, and they compared kids who were treated with steroids, systemic steroids, compared to the ones who were not. And in the ones who were treated, they actually had less hospitalization duration. They need less transfusion or exchange transfusion, depending on the case. They differvested quickly, so fever was for shorter duration, and their oxygen requirement and pain management was less. However, 15% of those kids have what we call rebound vaso-occlusive crisis within 6 days of discharge. And you can see the p-value is kind of like borderline, but it approaches significance of 27% versus 5% developing acute chest syndrome, 27% who used steroids and 5% who did not. So I think that was one of the studies that made everybody look at it. Other retrospective analysis was performed as cited here on the slide, and they found that the odds ratio of readmission within 14 days of treatment with systemic steroids led into 20-fold higher rate among patients who were treated versus who were not. And another retrospective study showed that, which contradicts the results, of course, that there was no rebound pain episodes or any other complications for kids who received systemic steroids with an acute chest syndrome. And this final study, we just have so far prelim data from the Comprehensive Sickle Cell Center that shows that there was a decrease in the hospitalization of around 1 day for kids who were treated with systemic steroids. Rebound pain crises were observed in both groups, but on a higher rate for those who received systemic steroids compared to the ones who did not receive it. So what do we do when we have a kid with acute chest syndrome? We just have to be careful. So if you need to use it, you are going to use it, but you should have selected patients. So for us, for example, I use systemic steroids on several of my patients, but I have to choose the kid who I know have lower lung function, they have recurrent admissions, they have prolonged episodes of wheezing. So it is case dependent. And when you use it, you're going to use a relatively lower dose. Try not to use the 2 per kilo like we do for asthma, unless you really need it for a sick kid, and try not to stop it abruptly. So do taper steroids, although it's a low dose, and there's no other clinical indication for tapering 2 milligram per kilogram per day for 5 days, but you're going to taper it with kids with acute chest syndrome to hopefully prevent a rebound crisis. Now, preventative strategies for the acute chest syndrome. As we mentioned earlier, operations are a risk, so preoperative blood transfusion, and of course this has to follow the guidelines and the level of HBS, and this is guided by the hematologist. If the kid is known to have asthma, you're going to make sure that the asthma management is optimized, and encourage your patients, as indicated, to use their hydroxyurea therapy. It was reported in the literature that hydroxyurea actually dropped the incidence of acute chest syndrome by 3-folds in the last 10 to 20 years since we started using it. And finally, as mentioned previously, the use of incentive spirometry in the hospital during an admission for a pain or vaso-occlusive crisis is found to be preventative for developing an acute chest crisis. Now, switch gears to another topic, asthma and sickle cell disease. I'm sure this is a very popular topic. So, what do we know so far about that? So, all of us know that asthma is the most common pediatric chronic illness, period. And we know that it's more common in the African American population, and it's more severe in the African American population. So in a recent study, the prevalence was 15% among African Americans compared to 8% in Caucasians, almost double. So does that mean that kids with sickle cell have more asthma? So we're going to see, what does the literature say about that? Is this true? So again, a lot of contradicting studies and contradicting results. So I just picked up a few, of those studies that I went over just to show you how the prevalence is different and they're contradicting each other's. So for example, some studies say that asthma occurs in a similar frequency in the African American population with or without sickle cell disease. So there's no difference. And 2 other studies actually have shown that asthma may be more common among those with sickle cell disease compared to no sickle cell disease in the African American population, of course. And some studies say that kids who have sickle cell disease and have asthma are more likely to develop the serious complications of vaso-occlusive crises and acute chest syndrome. Now, where is that coming from, and why are they contradicting each other? Going back to all of that literature that we find, we gotta be careful how we interpret the data. There's a lot of variation in the study design and in the definition of asthma. Everybody defined asthma differently. Some defined asthma as just positive airway hyperresponsiveness. You guys remember that metacolon challenge test and the cold air challenge test. So some authors actually defined asthma by a positive test, some of them by just a parent report of wheezing, parent report of asthma, physician diagnosis of asthma. And also, if we look at the design of the studies, none so far, up to the date of my literature search, of course, which is last week, there were no population-based studies for children who have sickle cell disease to compare them with completely healthy controls and then report the prevalence. All of the studies that we have are coming from just studying the sickle cell population without control, most of the time, in a tertiary center with, a pulmonologist who had higher threshold maybe of diagnosing asthma and wheezing. I just picked up this very nice table just to show you. If you look here at the prevalence, you can see a lot of variation, 17%, 28, 48, that's a lot of difference. And if you look back at the studies, you can see how they are different in the definition of asthma. Parent report, physician diagnosis, parent report of a touch of asthma, parents or patient answering a questionnaire. So we cannot actually take that, right? And most of the studies that we see also were small studies, relatively smaller size studies. So we need big ones, and we need big cohort studies with control, with normal controls. So now let's talk a little bit about asthma. So as you all know, what is asthma? Asthma, you have some respiratory symptoms of coughing and wheezing that is triggered by whatever the antigen or trigger, and it causes airway hyperresponsiveness. Then you take the bronchodilator and you get better, right? So how do sickle cell kids present? Do they have coughing and wheezing? Yes, they do. Do they have airway hyperresponsiveness? Yes, they do. Do they have asthma? The short answer is we don't know. And that's a little surprising, I know. We don't know. Why do we not know if this is asthma or not? Because going back to the literature, a lot of studies have reported, for example, that kids with sickle cell disease have higher airway hyperresponsive testing. And I just chose to remind you quickly how we diagnose airway hyperresponsiveness. If you guys remember the metacolin challenge test, where we have the patients inhale metacolin in different concentrations, and then we pick the PC20, which is the concentration at which the FEV1 drops by 20%. But I have to remind you that we do not use that test exclusively to diagnose asthma. It just tells me that this person has high airway hyperresponsiveness, but you can have that if you have a viral infection, right? So that's why it's actually contraindicated, or you can have that when you're on certain medications. So that's why there are contraindications and very careful prepping for this test. And even if we, have a abnormal test positive value, we do not use it without looking at the pre-test possibility or probability of having asthma, meaning that it's very important to take a very good history, physical exam, and correlate that with the results of airway hyperresponsiveness. So for them to use airway hyperresponsiveness as a methodology to say that kids with sickle cell disease have more asthma is not very accurate. That's why I chose to put this slide for you guys. So in a nice study, they actually reported that this study, the sickle cell and asthma cohort, as you can see on the slide, they reported almost 50% of the kids that they studied to have positive metacolin challenge tests of more than 4 milligrams, which is the cutoff value for diagnosing asthma. However, other studies that showed that there was no significance between the prevalence of positive airway hyperresponsiveness and metacolin challenge tests among kids with sickle cell disease. And a little more sophisticated study, actually, as cited on the slide, they looked at what we call the dose response slope, which is how much metacolin did we need to drop the FEV1 by a certain volume. So of course, as you can tell, the less the worse. So it did not have any difference in patients with sickle cell compared to non-sickle cell. But if we just not, look at the diagnosis of sickle cell and just have all the patients who had asthma, compare them with the patients who did not have asthma, of course the dose response slope was different. Does that make sense? If you just took sickle cell out of the equation, of course kids with asthma, previously diagnosed asthma, were positive for that. So again, the data is conflicting about the importance of airway hyperresponsiveness. Airway obstruction and inflammation, yes, they do have airway inflammation. Mice models of the NOC gene for sickle cell disease showed that they have 2 helper cell inflammatory mediators, which is similar to asthma. And they also studied the exhaled nitric oxide, which we use as a marker of eosinophilic inflammation or asthma. And they also found contradicting results. Some said it's equal, some said it's higher, and some said it's the same for sickle cell kids with or without signs of asthma. Another new idea that is actually emerging and getting a lot of attention now is, where is this airway obstruction in sickle cell kids coming from? Is it really airway disease, or is it just an increased blood flow to the lungs and, kind of congestion of the pulmonary vessels to the degree that they actually compress the adjacent airways? A few studies, you can find them in the literature, very new studies, relatively in 2014. They looked at kids with sickle cell disease and they measured the pulmonary capillary blood volumes, and they found that it correlates with findings of airway obstruction. It correlates with residual volume, which is air trapping, right? It correlated negatively with FEV1, that's airway obstruction, and also it's correlated with the R5, which is the way we measure airway resistance using impulse oscillometry, if you're familiar with this test, where you actually literally send sound waves inside the lungs and they reflect back, and you're able to calculate airway resistance by this method. So the blood flow and the engorgement of blood vessels in the lungs correlated with evidence of airway obstruction. So is that why they have airway obstruction? We have to know. And finally, they all have wheezing. In the emergency room, whether those kids have a previous diagnosis of asthma or not, they were found to be wheezing. But we still don't know, is this really asthma or not? So we have to be very careful and just know that it's a risk factor for developing more serious complications of pulmonary complications. But unfortunately, the NHLB guidelines does not recommend screening of pulmonary function testing. And they want you just to correlate the clinical findings with the pulmonary function test findings and do pulmonary function testing on selected population, which we do. Switch gears to another complications, pulmonary hypertension and sickle cell disease. Why is it important? Because, as we mentioned earlier, it's been noticed to be associated with higher morbidity and mortality. A quick reminder for you guys, how do we diagnose it? We diagnose it by right heart cath, when you need to have pulmonary arterial pressure of at least 25 or above. And it was reported that the higher the pulmonary hypertension, for each 10 millimeters, the mortality rate increases by 1.7 folds in kids with sickle cell disease. So you can tell how serious of a complication it is. And as you remember, according to the World Symposium on Pulmonary Hypertension, it was divided into 5 types according to the underlying pathophysiology. Sickle cell disease was moved recently from class 1, which is just a pulmonary artery pathology, to class 5, which is multifactorial and also unclear etiology. So we still have to investigate that. Why does it happen? Simply, there's a lot of talk about it, but I just kind of summarize that in one simple slide. So how does it happen? Due to chronic anemia, you have increased cardiac output, you have increased pulmonary blood flow, and as we said, that's kind of a trigger for increased pulmonary systemic pressure. And because of all of that engorgement, you can have vascular remodeling that can actually extend from the right heart to the left heart at some point. And this is exactly what we call early stages pre-capillary and late stages post-capillary pulmonary hypertension, when it's more severe. And also the hemolysis itself is a very important factor, which tells you not only sickle cell, but other hemolytic anemias also can induce pulmonary hypertension. How is that? Free hemoglobin can actually inhibit the production of nitric oxide, which is a very important pulmonary local vasodilator. It also releases arginase, which metabolizes arginine, which is the precursor for nitric oxide in the endothelial cells. And also free radicals can cause direct damage to the endothelial cells, producing less nitric oxide. And lack of nitric oxide will induce coagulopathies and will induce activation of platelets and thrombosis. So you can have the microemboli and you can have pulmonary hypertension. That's very brief. How we diagnose it? We screen by echo. If we find that the TRV, which is the tricuspid regurg velocity, at least 2.5, you're going to watch this patient. Now, does 2.5 correlate with significant pulmonary hypertension? Maybe, maybe not. The accurate diagnostic method is cath. So if you see, there's a nice diagram by the American Thoracic Society. If you have it less than 2.5, just observe, watch clinically. If you have it between 2.5 to 2.9, you're going to do other ways of assessing for hypoxemia and pulmonary defects by 6-minute walk test, by elevated BNPs. If it's positive, you do the right heart cath. And if it is more than 3, you're immediately going to send this patient to the cardiologist for right heart cath, because that number is associated with significant pulmonary hypertension and higher mortality. And as you can see, the guidelines from the American Thoracic Society do not recommend screening for little kids by echo. Maybe at the age of 8 or more, you can start doing like yearly echoes, unless, of course, you have a sick kid with recurrent acute chest syndrome episodes. Those, you're going to pay attention to them a little earlier, and you're going to start screening earlier. And then it's the same following the other slide of looking at the TRV and paying attention to the number, so it can dictate when you send those kids to the cardiologist. And finally, again, and unfortunately, they were not able to recommend for or against screening of asymptomatic patients for pulmonary hypertension. There wasn't enough evidence. Nice CT scan that shows you on figure A, you can see the dilated pulmonary artery, and you can see on C the dilated right atrium and right ventricle. Hopefully you can see that on the graph.
Try the mouse.
This one? Oh. All right. This is the pulmonary artery, right? And here you can see the dilated right heart, and you can see the engorgement of blood vessels with actually peripheral hypovascularity. So that's all like signs of pulmonary hypertension, engorgement here, and less vasculature on the peripheries. All right. Another topic, what happens with the pulmonary function test in sickle cell disease? Now, I know you guys all maybe remember that as a late complication, you can have pulmonary fibrosis. However, there's a lot of attention nowadays paid to other abnormalities in sickle cell disease, especially the obstructive pattern. So it happens, the fibrosis, but it doesn't happen as often as we thought it does, because this is a very late complication and it happens in adults. And also because there was a very nice review cited below by Dr. Comburlis. He looked at the articles that actually diagnosed restrictive lung disease in those kids, and he found that the definition of restrictive lung disease was also different from one person to the other. So we kind of need to go over that accurately, because as you guys all know now, if you have decreased FVC, that doesn't mean you're technically restrictive, because you can have increased RV that makes your FVC look lower, and that's air trapping. So probably it was over-reported and over-diagnosed a restrictive pattern. So we gotta need to pay more attention to the obstructive pattern, and we gotta pay more attention to the DLCO, the diffusion values. But this is a very nice CT scan that shows you the late complications, and you can see the subpleural honeycombing here where the arrows are. This is a sign of pulmonary fibrosis, and over here, little or honeycombing. And finally, what do we can see in sickle cell disease? We can see obstructive sleep apnea now is being under focus, because it's not as reported and studies as it should be, and it was found to be a very common complication contributing to the mortality of sickle cell disease. It was found to be more prevalent in sickle cell disease population than their healthy peers. And habitual snoring, which is not correlated in the normal individuals with the severity of obstructive sleep or the presence of obstructive sleep apnea, but it was correlated in the sickle cell population. Also lower waking, when the patient is awake in clinic, lower waking SpO2 values were correlated with mild to moderate obstructive sleep apneas, and also lower FEV1 that we test in clinic also was associated with mild obstructive sleep apnea. It wasn't found to be associated with higher, with more severe cases. We were trying to find why is it more common in sickle cell disease. I don't think we have an accurate answer as of today. But obviously, there was some reports of, which is expected and not surprising, to have reduced upper airway diameter and adenoidal and tonsillar tissue, which correlates also with the findings in the normal population. Now, screening is important, especially when you have overweight patients, you have habitual snoring, you have recurrent acute chest syndrome, because you're not only looking for obstructive sleep apnea, but you are also looking for nocturnal hypoxemia, which was found to be very common in kids with sickle cell disease, although they don't show signs of obstruction on their sleep studies, but they show unexplained hypoxemia. Of course, unexplained hypoxemia or nocturnal hypoxemia was associated with increased frequency of this acute chest and vaso-occlusive crises. And as we know, the treatment with hydroxyurea, as we mentioned earlier, probably have decreased the nocturnal hypoxemia that we see nowadays, and there's a positive correlation in the literature about that. So again, we don't know the incidence because we have asymptomatic kids who don't snore, so we don't send them to the lab, and we will never get insurance maybe for the sleep studies. So it is still under studies and underreported. But for us, we have to have a low threshold of picking up on those because they need to be on oxygen at night. And we have a fair population of kids of sickle cell who do not have obstructive sleep apnea, but they are on oxygen at night because of hypoventilation and hypoxemia induced by their sickle cell disease. You know this more than I do. Preventative strategies with vaccination, the PCV13, just following the American Academy of Pediatrics regular vaccination guidelines for healthy kids. In addition to that, they need to get the PPSV23, which is the polysaccharide that we give for splenectomized or under risk population. This should be given before the age of 5 years, even if they were vaccinated fully by the PCV13 or PCV7. You have to repeat the PCV13. And you all know that we use amoxicillin for kids, especially under 5 years, unless indicated otherwise. And for some reason, you have to prolong the duration of treatment with the penicillin, and you can have your immunologist help you. We have used that in some situations when we have kids come with recurrent bacterial infections and empyema in the ICU. We choose to prolong the use of amoxicillin. Now, a couple of slides about what we do. So why did we choose to do a multidisciplinary clinic for kids with sickle cell disease? Just because in general, multidisciplinary service is a kind of service that promotes integration of clinical and non-clinical services to, hopefully provide better care and better outcomes for our patients. And there are documented studies, especially a nice one I cited here from England. If you just look at the rate of hospital admission, how it dropped down significantly after they started the multidisciplinary clinic for sickle cell disease. And also there are other examples of such models in the US, actually in Bethesda, in Tennessee, in California, and among others. And we're trying to be one of them. But this is how it helps your population. And if you just look at the number of clinics each kid has to go to, I mean, this is just kind of impossible. And each physician wants to see them 3, 4, 5 times a year, depending on the severity of the condition. So what we do here, we're still actually not completely multidisciplinary because we have only pulmonary and hematology. We have nurse coordinators, we have part-time social workers and dietitians that help us, but we do not have still the full model. We're in the process. So we started this clinic last year. We have almost 400 sickle cell patients. We have 171 patients diagnosed with acute chest syndrome, and we can perform insight, pulmonary function tests, blood testing for the hematologist. We can perform echoes and chest x-rays in that clinic. So just wanted to give you a little brief about what we do. And thank you for listening. Anything unclear or any questions, you guys? Yes, sir.
The studies of asthma, thank you for your name. On the studies of asthma, did you find anybody who has done biopsies?
No.
Inflammation?
No. I actually think this is a very important topic, and I myself have the idea, but it's a very vulnerable population, and you have to be very careful with IRB. So, but no.
The other question I have is on the hypoxemia, patient with hypoxemia. I mean, we know that the reading of the sat draws in these patients, because of the Sickle component that they always have, is not as accurate. And sometimes we correlate with blood gases. Do you find any protocol that says that?
Did I find any
protocol when to check a blood gas and the level of hypoxemia? Is it only on your sat monitor? Because sometimes the sat monitor will not correlate with the PA.
Yes. So I don't think from the studies that I went over anybody did like arterial blood gas Is that what you asked?
Yes,
Because you
yes.
know that pulse ox is not as accurate. But I don't think any of them actually paid attention to that, and they all just recorded the PCT, CO2 and PSO2, but no arterial blood gas. Yes, sir.
For pulmonary hypertension, you said for screening by echo between the ages of 8 to 18 or probably above. Why not below 8?
Just because it wasn't cost effective. When they all sat together to come up with the guidelines, we do not have evidence that would make it cost effective to screen kids like we do for example, for the brain, right? We do the transcutaneous ultrasound. That was more cost effective for them to screen than the echo, and probably because of the incidence too. But that's all why it is not recommended. But I have to tell you, we don't necessarily follow that. For me, if I have a kid with obstructive sleep apnea and asthma, I would do an echo, right? Long-standing obstructive sleep apnea, recurrent wheezy episodes and hypoxemia, sickle cell disease, I would do an echo. Those are guidelines. It doesn't necessarily mean that we follow them very strictly. And I kind of mentioned earlier that you have to take it case by case. So for kids who have 2 or more acute chest syndromes and are on asthma medications, I would definitely screen them. But that's not the guideline.
Do you guys use the name of sickle cell lung disease obstructive or restrictive component?
Do we use what? I'm sorry?
The term sickle cell lung disease obstructive or restrictive component? Or mixed?
No. No, we don't. Is this because you want it to be accurate and not call it asthma?
Yeah, exactly.
I don't think there's no ICD-10 code for that.
No, but there are articles that call it that.
Absolutely,
Yeah.
yes. And actually,
Then you don't compromise.
yes, true, yeah, very good point. But no, I just, for myself, I call it recurrent wheezing. If I was not sure, but because you have to also treat them like other kids.
Yes.
You're going to ask about family history. You're going to ask about eczema. You're going to do allergy skin testing. You're going to look at response to albuterol. So if I see all of that, I'm going to call it asthma, right? But if I just have a sickle cell kid who wheezed, I will not call him an asthma kid unless I have another evidence of asthma, because as mentioned in those studies, and it's fascinating, that maybe, you can imagine the airways, they're maybe just pushed, pushed close by the blood vessels. Maybe they're just inflamed and swollen because of the inflammation resulting from sickling. It doesn't have to do anything with albuterol or steroids. So,
Thank you.
yes, sir.
How long do you take as far as screening down to steroids?
Tapering?
How many days would we?
I do it for 2 weeks, over 2 weeks, very slow. Yeah, very slow.
When a child comes in status asthmatic, do you guys adjust the IV steroid dosing? Like if you usually do it every 6 hours, but you were saying not to go over 2 mils per kg per day.
You mean the methylpred in the ICU? We don't. So we don't adjust the total daily dose. We just play with the tapering. So those kids usually go home on the equivalent prednisone dose, tapered over 2 weeks. But thank God I have not seen status in acute chest syndrome. But I assume you mean a sick kid with acute chest and wheezing, right? But like definition, status, closing, needs a lot of albuterol to open up. I have not seen that, but of course it can happen. Yes.
Are there any studies about how often pediatricians are following the prophylactic antibiotic and vaccine recommendations? Is that like an area?
I have not looked at that, to be honest, as part of my preparation, but that's a good point. Sorry. Yes.
Just going back to the steroid question,
Uh-huh.
what if you use one-time dose Decathlon? Because that sometimes that can be used for asthma management, asthma exacerbation, just one dose of Decathlon. So do you have experience with like you shouldn't use that, you should only use prednisone so that you can taper it?
Very good question. Actually, some of the studies that I mentioned, they looked at Decadron, and the rebound also was associated with Decadron too.
So basically, you would suggest not use Decathlon and use prednisone?
Unless you somehow taper it. We know we don't use Decadron for longer than 3 days, right? So that would actually maybe force you not to taper it. So that's why we prefer, and of course this is consensus, this is just the author's consensus, there's not a lot of evidence, But the consensus is to use prednisone and taper it slowly. We don't have, randomized controlled studies. We're just coming up with those recommendations based on the negative outcomes.
Also, sorry, in the same line, what about the combination of albuterol and Attrand in the...
Like Dulux? Yeah,
the
a combivent, yeah.
Yeah.
What about it?
So, like, in acute exacerbations, does it help?
We use it. Actually, it's funny how it's recommended with an acute chest syndrome episode, whether the kid has or has not had a previous history of asthma, you're going to put them on the bronchodilator around the clock. And the reason is we don't know still. We still need a lot of studies to figure out what's going on. But it's recommended to use it around the clock, no matter what the history was. Short answer, yes. All right. Thank you guys for listening.